Calcium oxalate crystals, which look like grains of sand, come together to form kidney stones. These stones can inflict severe pain. Now imagine having to deal with recurrent kidney stones, which could be a sign of multiple genetic disorders that go undetected for years. One of these genetic conditions is called primary hyperoxaluria, or PH. Primary hyperoxaluria is a family of rare autosomal recessive disorders in which the liver overproduces oxalate, an end product of metabolism in humans that has no known benefit. Oxalate is normally excreted by the kidneys. Then what happens differently in people with PH? Well, the genetic mutations lead to certain enzyme deficiencies in the hepatocyte, causing overproduction of oxalate. There are 3 known types of PH: PH1, PH2, and PH3, which are caused by one of 3 different mutations. As a result, the breakdown of glyoxalate is disrupted. Glyoxalate then starts to build up in the cell's cytoplasm. Regardless of the PH type, excess glyoxalate is broken down into oxalate by the hepatic enzyme LDH in the final stage of oxalate overproduction. The overproduced oxalate then travels to the kidneys, where it is normally filtered along with other waste and harmful products. When excess oxalate accumulates, it starts to bind with calcium, forming calcium oxalate crystals. These crystals may clump together to form kidney stones, also known as nephrolithiasis. The stones can cause obstructions in the kidneys, the urinary tract, and the bladder. Multiple surgical interventions, which can cause damage to the kidneys, may be required to remove stones. Calcium oxalate crystals can also cause nephrocalcinosis, or calcification of the kidney. Calcification causes kidney damage, infection, and inflammation, and reduces the kidney's filtering ability, leading to a decline in renal function. If untreated, this can lead to chronic kidney disease and eventually end-stage renal disease, which may require dialysis and a dual liver-kidney transplant. Systemic oxalosis occurs when eGFR drops below 30 to 45 milliliters per minute. In systemic oxalosis, the excess calcium oxalate that cannot be filtered by the kidneys escapes and starts to deposit in the tissues of the skin, heart, eyes, and skeleton. Early diagnosis, along with aggressive supportive treatment, can reduce the formation of new kidney stones and slow the progression to end-stage renal disease and systemic oxalosis.